I want you to imagine sitting down to dinner. You're eating something totally normal, just a meal you've had 100 times before.
Right, something completely routine.
Exactly. But suddenly, you experience this intense, totally inexplicable burning sensation in your mouth.
Oh, wow.
Yeah. Or imagine dealing with a chronic, unexplained burning in other highly sensitive areas of your body, a pain that just will not go away.
No matter what you try, right.
Right. It's this deeply frustrating, completely invisible pain that millions of people suffer from right now. And, they often suffer in total silence.
Well, that invisibility is exactly what makes it such a profound kind of suffering. I mean, when a patient tells their doctor that their mouth or their skin feels like it's literally on fire.
But there's nothing there.
Exactly. The doctor looks and sees no redness, no ulcer, like no obvious physical injury. It's incredibly isolating for the patient.
Because people start to wonder if it's all in their head.
Yeah, but the pain they're feeling is intensely real.
And validating that reality is exactly our mission for this deep dive today. We are going to unpack the fascinating microscopic relationship between the thinning of our body's mucous membranes, what they call mucosal thinning or atrophy,
Right.
and the painful exposure of sub-epithelial nerve endings. We want to find out exactly how and why a thinner physical barrier leads to these localized burning sensations.
It's a journey that I think will fundamentally change how you view chronic pain. Because, we aren't just talking about a random sensation here.
So what are we talking about?
This is really a story about how our anatomy physically interacts with our environment on a cellular level. And the absolute chaos that ensues when the delicate balance of that border breaks down.
Okay, let's unpack this, because before we can really understand why the mucosa burns when it gets thin, I feel like we need to establish a baseline.
Oh, absolutely.
Like, how is this tissue and its internal alarm system actually supposed to work when everything is healthy?
Well, to picture that, you really have to imagine the blueprint of our body's borders. So think of the oral mucosa or the vaginal mucosa as this highly specialized, multi-layered security wall.
Okay, a security wall.
Yeah. The very top surface is the epithelium. And if you were to look at it under a microscope, it isn't just a flat, smooth sheet like a piece of paper.
Right. I was actually looking at the anatomical diagrams for this, and it looks almost like a landscape of valleys and peaks with these inward projections that kind of anchor it down.
Yeah, exactly. Those are called epithelial pegs. They grip the layer directly below, which is the lamina propria.
The lamina propria.
Right. And the lamina propria is this dense connective tissue layer. You can think of it as the vital supply line. It holds all the blood vessels that form this rich sub-epithelial capillary network.
To feed the tissue above it.
Exactly. And crucially for our discussion today, it houses the nerves. Then below all of that is the submucosa, which attaches the whole membrane to underlying structures.
Like muscle or bone.
You got it.
So the nerves are sitting right there, just under the surface, in that supply line layer. The medical literature refers to these as unmyelinated C-fiber axons.
Yes, that's the technical term.
And just to clarify for everyone, unmyelinated means they don't have that fatty, protective myelin sheath wrapped around them, right? Like, they are raw sensory receivers.
That's right. They are designed to be raw and sensitive, so they can immediately detect changes in the environment. And right alongside them, you have Merkel cells.
What do those do?
They are slowly adapting sensory touch receptors, located right in the basal layer, so the very bottom layer of the epithelium. They hold these tiny packets of transmitter molecules.
Oh, interesting.
Yeah, they're ready to fire across a synapse to a nerve fiber just to tell you, what your tongue is in your mouth, or to sense a very light touch.
The analogy that helps me picture this whole setup is a standard electrical wire.
Oh, okay, I like that.
Yeah, so the thick, healthy epithelium is like the heavy rubber insulation wrapped around a live copper wire.
Right.
The nerves, those unmyelinated C fibers, are the copper. So as long as the rubber insulation is thick and robust, the copper is protected from everyday wear and tear.
It's shielded.
Exactly. The nerves only fire off a major distress signal when a legitimate, powerful, external, force-like, extreme tissue-damaging heat actually manages to penetrate that thick rubber insulation.
I really like that analogy because it highlights the protective function of the tissue so well. And this specific alarm bell sitting on those copper wires is a receptor protein called TRPV1.
Okay, wait. I actually recognize that name from the sources. TRPV1 is the capsaicin receptor, right?
It is, yeah.
It's the exact same receptor that gets triggered when you eat spicy chili peppers and makes your mouth feel hot.
It is, but calling it just the capsaicin receptor is a little misleading. I mean, Evolution didn't design this receptor just so we could enjoy spicy food on a Friday night.
Fair point. So what's its actual day job?
TRPV1 is actually a general noxious sensor. Its primary job is to detect danger and prevent tissue damage.
Danger like,
Well, it is activated by noxious heat, specifically temperatures over 43 degrees Celsius, which is about 109 degrees Fahrenheit.
oh, wow. So literally hot things.
Literally hot, yeah. It's also triggered by a low pH, meaning highly acidic environments below a pH of 6.5, and by various inflammatory lipids that your cells release when they are injured.
Oh, I see. So capsaicin just happens to chemically trick this built-in heat sensor into firing, making us feel a burning heat that isn't actually there physically.
Exactly. It hijacks the alarm.
But the body doesn't just leave these receptors wide open all the time, right? I
Right.
mean, otherwise we'd be in constant agony. There has to be some sort of regulatory mechanism.
Oh, there is a very tight regulatory system.
Yeah.
TRPV1 is a highly sophisticated environmental sensor constantly calculating the threat level. It's not just a simple binary on or off switch.
So it's more like a dial.
Kind of. It actually sits balanced right on the edge between an open and closed state. In a healthy resting state, a specific lipid in the cell membrane called PIP2 acts kind of like a bouncer at a club.
A bouncer? Okay.
Yeah, it binds to the TRPV1 channel and keeps the door locked closed.
Okay, so PIP2 is the bouncer or the brake, keeping the alarm quiet. What takes the brake off?
When your tissue gets damaged, your cells release an enzyme called phospholipase C. You can think of phospholipase C as a pair of molecular scissors.
Molecular scissors type.
It comes in and literally cuts that protective PIP2 lipid away. The bouncer's gone, the brake is removed.
Wow.
And at the exact same time, the body releases things like nerve growth factor, or NGF, which acts as an accelerator, springing the channel wide open.
Okay, so if this thick rubber insulation of the epithelium is what normally keeps the peace, preventing everyday things from triggering those molecular scissors, what causes that insulation to break down?
That's the big question.
Yeah, like how does a thick, healthy tissue actually thin out in the first place?
Well, this is the core mechanic of atrophy. The first thing to understand is that the epithelium isn't static. It is incredibly dynamic, constantly shedding old cells and generating new ones. But maintaining that massive, rapid cellular turnover requires a massive amount of resources.
And when we look at something like the vaginal mucosa, the primary resource driving that turnover is hormones.
Right, exactly. During a healthy, normal menstrual cycle, the thickness of the vaginal epithelium completely fluctuates based on estrogen levels.
I read that around day 14, which is ovulation, when estrogen is peaking, the tissue thickens up to 45 layers of cells.
Yes, 45 layers. It becomes incredibly cohesive, and the cells are packed with glycogen.
Let's pause on glycogen for a second because that seems really important.
It is. Glycogen is essentially stored cellular energy, like a form of sugar. When the cells are packed with it, they are plump, robust, and structurally sound.
So they form a massive, thick physical barrier.
Right. But look at what happens when that resource is withdrawn. During menopause, for example, estrogen levels plummet. Without estrogen driving that cellular proliferation, the tissue literally loses its structural integrity.
It just can't keep up the rebuilding process.
It can't. It loses collagen, which provides the firmness.
All right.
It loses elastin, which provides the stress.
So it just kind of degrades?
Yeah, that thick top layer of superficial cells diminishes, and the tissue becomes dominated by what are called peribasal cells.
Peribasal cells.
Basically, they are smaller, less mature cells. They haven't developed into the tough, protective outer layer yet. So blood flow diminishes, and the tissue becomes dry, inelastic, and dangerously thin.
I was looking at the optical coherence tomography measurements in the sources, the OCT data, where researchers actually map this out in living patients, and the sheer physical loss of tissue is staggering.
It really is.
We aren't talking about a microscopic scrape here. A healthy, normal vaginal epithelium is about 503 micrometers thick. That's roughly half a millimeter.
Right.
But in mild atrophy, it drops to about 261 micrometers. It's almost cut in half.
And in severe atrophy.
It plummets to just 158 micrometers. The mucosal folds, like the natural structural ridges of the tissue, they just completely disappear. It goes entirely flat and paper thin.
It's a dramatic structural collapse of the protective barrier. And, while estrogen is a major driver for vaginal tissue, it's not the only resource the mucosa relies on throughout the body. Iron is another critical building block.
Right, which leads to a condition called atrophic glossitis affecting the tongue.
Yeah.
A healthy tongue is usually covered in these little bumps, the filiform and fungiform papillae. They are literally the armor of the tongue, providing a protective textured layer and housing the taste buds.
Exactly.
But when a patient suffers from iron deficiency anemia, their body is starved of iron and it can't maintain that rapid cell turnover. The tongue loses those protective papillae.
It becomes abnormally soft, completely smooth, and highly vulnerable.
Yeah, clinical studies showed nearly a quarter of patients with iron deficiency develop fissured or deeply grooved tongues as a result.
It's a very striking visual and physical change.
Wait, hold on. I'm thinking about the timeline here. If someone has an iron deficiency or they are entering menopause, this tissue isn't just vanishing overnight, right?
No, not at all.
Are people just walking around slowly losing their biological armor, like micrometer by micrometer, without even realizing it until they cross some critical threshold?
Unfortunately, yes. It is an incredibly insidious process.
Yeah.
Atrophy isn't an acute localized accident, like burning your mouse on hot coffee.
Right. It's not a burn injury.
Exactly. It is the
Yeah.
downstream effect of a systemic loss of resources. Whether that resource is a vital mineral like iron or a master regulator hormone like estrogen, the body begins rationing.
Because it has to prioritize.
Right. The tissues that require the most energy to maintain, like the fast turning over tissues of the mucosa, are often the very first to show the signs of that systemic starvation.
Wow.
It happens slowly, silently, until the insulation is worn so thin that the underlying nerves are left completely exposed to the outside world.
Okay, so the physical barrier is now dangerously thin. We've dropped from over 500 micrometers down to under 160. The rubber insulation is completely worn down to the copper wire.
Yes.
But how does this physical thinning actually trigger the biological sensation of a burning fire in the patient?
Well, it comes down to diffusion and direct access. When you have a thick, healthy epithelium, the things you interact with, spicy foods, acidic drinks, or just the mechanical friction of everyday life, they stay on the surface.
They don't penetrate.
Exactly. They do not penetrate deep enough to reach the sensory nerves buried down in the lamina propria. But with a thinned-out, compromised epithelium, those same everyday irritants can easily diffuse right through the tissue.
It's like a medieval castle.
A castle.
Yeah, if the outer stone wall, the epithelium, is thick and strong, the invading army stays outside. But if that wall is reduced to rubble, reduced to 158 micrometers, the enemy, like the spicy salivary components, the mechanical friction, can literally walk right up to the castle's inner alarm bells. They walk right up to those TLPV1 receptors and ring them directly.
That's a great way to look at it. That direct physical access is a massive part of the problem. You are putting noxious stimuli right up against the unmyelinated C fibers. But the medical data reveals it's actually worse than just direct physical exposure. Those exposed nerve fibers don't just sit there passively enduring the assault. They undergo a profound pathological change.
Oh, I was reading about this in relation to burning mouth syndrome. When the epithelium thins and the nerves are exposed, the longest, most vulnerable unmyelinated C fibers actually begin to degenerate.
Yes, exactly.
It causes a length-dependent neuropathy.
Right, and neuropathy simply refers to nerve damage or dysfunction. When these specific small fibers are damaged by the constant exposure, they don't signal a normal dull ache.
What do they signal?
They signal a very specific agonizing type of pain, decreased temperature sensation, and a severe spontaneous burning or electric shock-like pain. The electrical wiring is actively fraying.
But here's the paradox that really caught my attention in the sources. The nerves are degenerating and fraying, yes, but the fire alarm is actually getting louder.
It really is.
In burning mouth syndrome, the epithelial nerve fibers that manage to survive show a massive, significant increase in the TRPV1 receptor itself. And along with that, a huge spike in nerve growth factor, or NGF.
And this is the absolute crux of why the suffering is so intense. The pain isn't just a physical exposure issue anymore. It has become a biochemical feedback loop. Yeah, the nerves are actively mutating in response to the trauma. The body senses the structural damage and releases nerve growth factor to try and repair the frayed nerves.
But as we established earlier, NGF acts as an accelerator.
Yes, it strips away the PIP2 brake on the TRPV1 receptor, springing it open and hypersensitizing it.
So wait, in its desperate attempt to heal the damage, the body is sprouting more heat and pain receptors and simultaneously bathing them in a chemical that makes them hypersensitive to any stimulus.
Exactly.
All at the exact moment that the tissue has completely lost its physical structural shielding. It is the perfect biological storm for chronic burning pain.
It truly is. The volume dial on the pain receptors is being cranked up to 10, while the soundproofing of the room is being completely torn down.
I mean, I'm trying to picture the real-world impact of this. If those nerve endings are fraying, multiplying, and firing constantly, how does this manifest in the patients who actually have to live with it?
Well, we can look closely at two major syndromes that were highlighted in the data. Genitourinary syndrome of menopause, or GUSM, and burning mouth syndrome, BMS.
Okay.
Both are devastating in their own ways, and both heavily rely on this exact mechanism of mucosal thinning and nerve sensitization.
With GUSM, the clinical reality is severe psychosocial distress. The symptoms include intense vaginal dryness, bleeding, an elevated pH, which changes the whole local microbiome and invites chronic infections, and severe dyspareunia, which is painful intercourse.
It's an agonizing disruption to a person's life.
And it all stems from that microscopic structural collapse down to 158 micrometers of tissue and the subsequent exposure of those hypersensitive nerve endings.
Yes. Then you have burning mouth syndrome. This is often classified as an idiopathic condition, meaning it seems to happen spontaneously without a clear external trigger.
Right.
It primarily affects 1.5 to 5.5% of middle-aged and elderly women. These patients live every day with a mouth that feels like it's literally on fire. Clinical tests show they have a strikingly low tolerance to noxious heat and capsaicin compared to healthy controls.
Because their TRPV1 receptors are just trapped in a state of constant firing.
Exactly.
Now, you just mentioned that burning mouth syndrome primarily affects middle-aged and elderly women, and that leads to this fascinating hormonal paradox regarding the gender divide in these conditions.
Oh, this part is fascinating.
Yeah, the clinical data shows that the female sex hormone 17-estradiol dramatically potentiates or enhances the capsaicin responses at the TRPV1 receptor.
Right.
Meanwhile, the male hormone testosterone actually has a marginal inhibitory activity. It slightly dampens the receptor's sensitivity.
It's a very significant physiological difference in how male and female sensory nerves are fundamentally tuned.
But let me make sure I am understanding this cruel biological irony correctly. Women are essentially pre-wired by their own estrogen to be naturally more sensitive to burning pain at the TRPV1 receptor.
Yes, the system is primed.
But then, when they hit menopause and lose that estrogen, the resulting physical thinning of their mucosal tissues, combined with the spiking nerve growth factor trying to fix the damage, creates a secondary, entirely new pathway for even more intense burning.
That's right.
So they get hit on both ends of the hormonal timeline.
Yes, they do. Estrogen sensitizes the receptor while you have it, but it also maintains the structural integrity of the tissue and regulates the nerve growth responses.
Oh, I see.
Importantly, estrogen normally suppresses the NGF signaling to TRPV1. So when estrogen drops precipitously at menopause, the tissue thins, the nerves are exposed, and that suppression of NGF is just lifted.
So NGF concentrations spike.
Exactly. That spike in NGF cranks open the TRPV1 receptors, resulting in highly increased pain sensitivity in postmenopausal women. It is a cascading failure of the body's protective systems.
That reframes the entire conversation around chronic pain for older women, doesn't it? It's not just a vague complaint, it's a mechanical failure.
It absolutely rewrites the narrative. We have to stop viewing chronic pain in older age as just an inevitable, unavoidable decay, or worse, some psychosomatic issue.
Right, it's not all in their heads.
It is a highly specific, measurable neuroendocrinological cascade. The tissue physically thins, the nerves are structurally exposed, the receptors biologically mutate, and the hormones that once regulated the entire system disappear.
But the vital silver lining here is that because this is a specific mechanical and biochemical cascade, if we map it out, we can theoretically intercept it.
Yes, theoretically.
Right. Researchers are already looking into selective TRPV1 and NGF blockers as potential therapies. If we can chemically block the receptor or block the NGF that is springing it wide open, we could potentially turn off the fire alarm even if the castle wall is still thin.
It totally moves the goalpost for treatment. Instead of just offering a temporary soothing mouthwash or a topical lubricant, medicine could actually address the cellular misfiring that is causing the agony in the first place.
We've covered some incredible ground today. We started with the simple act of a spicy meal or a sudden physical discomfort, and we traveled right down to the microscopic thinning of the epithelium.
It's a long journey down to the cellular level.
It really is. We watched the protective rubber insulation wear away, exposing the sensitive copper wiring of the C fibers. We saw the biochemical explosion of the TRPV1 receptors sprouting and screaming as nerve growth factor flooded the local area.
It's a vivid reminder that localized burning sensations, whether in the mouth, the genitourinary tract, or anywhere else, are a real physical collision. It is the microscopic collision of tissue loss and hyperactive nerves.
So the next time you or someone you love experiences that unexplained, invisible burning sensation, you now know the fierce cellular battle taking place just fractions of a millimeter beneath the surface.
It might be completely invisible to the naked eye, but it is deafening to the nervous system.
Exactly.
Understanding the why behind the pain is incredibly empowering. It validates the experience of patients who have been told for too long that there's nothing visibly wrong with them.
Yeah,
Knowledge really is the first step in managing the condition.
absolutely. But before we wrap up, there is one more lingering concept from the research that we didn't fully unpack today, but it is too fascinating not to leave you with.
Oh, the endocannabinoids.
Yes.
Hmm.
We spent all this time talking about external triggers and pain pathways, but we know that the human body naturally produces a molecule called anandamide.
Right.
It's an endogenous cannabinoid, meaning it's a molecule very similar to the active compounds in cannabis, but it's manufactured naturally by your own body. And incredible research shows that anandamide can actually bind to the inside of the TRPV1 receptor.
It's amazing. It is transported straight across the cell membrane to regulate this specific pain sensor from the inside out.
Right. So if our own bodies possess an internal system capable of regulating these exact same fire alarm receptors from the inside,
Mhm.
could the future of pain management lie not in applying topical gels or taking systemic painkillers, but in finding a way to coax our own cells to release these natural endovenoids?
That's the million-dollar question.
Could we teach the body to extinguish its own invisible fires from within? I'll leave you to ponder the hidden pharmacy inside your own cells, because even when the insulation is gone, the body just might still have a way to cool the wire.